Welcome to AETCM, the Emergency Medicine Channel. So today we received a 63-year-old female who came with sudden onset breathlessness complaints. Sir. So on arrival,
no past history of any disease?
Sir, the past history is of a metastatic carcinoma of breast, which is on letrozole medication as chemo, hormonotherapy she is having. Right now the patient we have taken into the ear and started with the primary survey. On primary survey, the patient airway is patent. She is able to talk in one full sentence. And the respiratory, coming to breathing respiratory rate was 22 per minute and saturation was maintaining at 98% of the room air. Right-sided chest raise is slightly lower than the left-sided chest raise, sir. Apart from that, coming to the next circulation, patient pulse rate is 97 per minute and BP is 140/90. Peripheral pulses are palpable and disability wise patient having GCS of E4, V5, M6 and pupils bilaterally reactive to light. Exposure wise patient is afebrile and GRBS was 140 mg per dl. Coming to the adjuncts to the primary airway, we couldn't get any VG, we got a VBG taken at that point of time. pH was 7.429 and bicarb was 31.4. In that VBG sample, PCO2 was 48.2. No electrolyte imbalance, lactate was 1.2, sir. And
oxygen saturation? In the
VBG oxygen saturation 27.2. VBG.
Okay. So, both are reduced even then, even if it is VBG,
yes, sir.
Both are reduced.
And the bicarb was on the higher, sir. 31.
Okay. pH?
pH 7.429.
Okay. Is there any difference between pH of arterial sample and venous sample?
Yes, sir. 0.3. 0.3.
Okay.
ECG showing normal sinus rhythm.
It is not 0.3, 0.03.
0.03.
Okay.
0.03. ECG showing normal sinus rhythm, sir, at the adjuncts. Next, coming to the detailed history, patient has past comorbidities of hypertension and carcinoma of breast. She is on right now treatment of letrozole and palbociclib. And she has a history of pleural effusion, for which she was admitted just 2 days ago.
Okay.
On right-sided pleural effusion, she was tapped and sent home.
Right now, fluid, hemorrhagic or
it was clear cystic fluid, for which cytology had been sent in view, has been sent because she is having carcinoma breast. Right now, she came with complaint of sudden onset breathlessness, sir. And also there is no any history of any allergy to medication. And the other history she has given is there is a right-sided lower limb swelling for the last 4 days.
Okay.
Which is having pain while walking.
Okay.
On examination of the first systemic examination, no pallor, no icterus, no lymphadenopathy. And coming to the respiratory examination, on inspection, the right-sided chest is having reduced, the left-sided chest is rising, but right-sided there is no chest increase. And on auscultation, there is reduced air entry on the right-sided, lower half of the right-sided, sir. And coming to the right lower limb examination, in right lower limb, there is no any increase in temperature, and further evaluation wasn't examined because we had put in mind DVT might be one of the...
Okay. DVT, what should be the basic steps followed in emergency room?
First is don't examine.
That is the most important. Okay.
So at this point of time, we asked for an ultrasound.
What are the examinations described in textbooks?
When you press pain, Hampton's test,
squeezing the
calf muscle pain,
flexing the ankle joint. All these things are contraindicated in DVT. So
we went ahead with the ultrasound of the right lower limb. In the ultrasound, it was seen that there is a reduced venous flow in common femoral artery and
How do ultrasound help in a limb swelling? What all things you can see in ultrasound?
We can see if there is edema, peripheral, subcutaneous
can be
edema,
picked up. Okay, one is that.
and if there is any thrombus in the vein,
Vein collapsibility,
can
be
be seen.
picked up. Third one.
Flow, arterial.
Arterial Doppler, normally will arterial obstruction produces edema? What it will produces?
Produces
Ischemia and gangrene. It will not produce edema. What else you can see? Lymph nodes. Like you can look for any lymph nodes in the lower limb. Okay. So these three things you have to ask. Okay.
After which
so only flow is reduced in that limb, swollen limb.
Yes, a flow, thrombus is seen, sir.
Thrombus is seen. Okay.
Yes, sir. After which the suspicion of first we prognosticate with the Wells criteria to see whether it is a high risk pulmonary, high risk or the low risk, two categories. Modified Wells scoring system has been done. In modified Wells scoring, the clinical symptoms of DVT were present, so 3 points. Likely diagnosis of pulmonary embolism is there in this patient because she has developed sudden breathlessness, and 97 heart rate being slightly tachypneic. So 3 points for likely diagnosis of pulmonary embolism. Heart rate greater than 100, as it's 97, no points were given for it. Immobilization for greater than 3 days or surgery in the previous 4 weeks. There is a pleural effusion but not a surgery, so that was not taken. And previous...
And pleural effusion part of pulmonary embolism? Can it be? It is a part of pulmonary embolism.
Complication of pulmonary embolism.
Yes. Part means it can
cause.
Yes. Okay.
Previous DVT or PE is not there in this patient, so 0 point for that. No hemoptysis, and malignancy was there, so 1 point. Total score was 7. So it's a high risk of pulmonary embolism as per the Wells criteria.
So in this patient, she had past history of malignancy.
Yes, sir.
Last 2-3 days, she was hospitalized due to some reason. So that itself can induce an embolism, and she is already on procoagulant state. That is a malignancy.
And also now we have diagnosed as DVT, so clearly we can, as DVT is a major risk factor of the pulmonary embolism, so we can expect a pulmonary embolism in this patient. So as we have ruled out if there is any contraindication to give.
What is the difference between pulmonary infarction and pulmonary embolism? Both are same.
Embolism causes infarction and
both are same.
Both are same.
What is the blood supply of lung? It has got an artery and it has got a vein. And that artery thrombus in the artery is infarction actually. That produces severe pain, like pleuritic chest pain, all these things. Mechanism may be same, but both are in different areas. Okay. Pulmonary embolism normally produces from the distal area that is embolized to that area. Infarction is like your heart attack, stroke. The arteries are involved. Okay.
Because of the high risk of pulmonary embolism as per Wells criteria, and no any contraindication to give the heparin anticoagulant, initially we can start with giving a stat dose.
What are the other investigation you can do in the emergency room to make a probable diagnosis of pulmonary embolism? It's only probable diagnosis.
The other investigations would be requiring D-dimer and CT.
D-dimer, what will happen to D-dimer?
D-dimer is a sensitive test in pulmonary embolism, but not specific. D-dimer will raise.
Can be positive in many conditions.
Yes.
But if it is negative?
If it's negative, then we can. There can be
embolism is ruled out. Okay, so it's used mainly for ruling out pulmonary embolism. Then other investigations?
Another investigation would be, there is no specific test, like we can do chest x-ray, ECG, bedside echo to see the...
Okay, chest x-ray, what finding you get?
We can, main findings are Hampton sign to see if there is any oligemic fields, or Westermark sign to see wedge-shaped infarct pulmonary.
Echo?
In echo, right atrium and right ventricle dilation can be noted. Right ventricular hypertrophy, if it is a chronic case. We can see if right ventricular systolic failure is there, that is indicating a pulmonary embolism.
McConnell sign?
McConnell sign would be the right ventricle apex regional wall motion defect.
Okay. These are the common finding. Most important is if there is a massive pulmonary embolism, right ventricular dilatation will be there. If it is massive, if it is small, nothing will be there. ECG finding?
ECG finding, specific finding, initial finding would be the tachycardia is the first finding.
Most common thing is tachycardia.
Tachycardia.
Okay, then?
Then V1 to V4 T inversions. A specific finding for pulmonary embolism is S1, Q3, T3. S1 in prominence in V.
Other common findings? S1, Q3, T3 is very specific, but it is
Rarely
rare. Okay. Other things? Other than tachycardia?
T inversion in V1 to V3.
Okay. Anterior leads T inversion, then? RBBB?
RBBB, atrial fibrillation.
RBB with strain pattern is another common, it's not common, another important finding. If previous ECG was not showing and this ECG shows RBB,
Right axis deviation.
that right axis deviation is another finding. Okay.
In this case, like first we had to load with the
What will happen to P wave in pulmonary embolism? What is acute cor pulmonary?
Acute cor pulmonale is because of the right ventricular failure. Any right ventricular failure is cor pulmonale as this. If there is a sudden saddle type pulmonary embolism or bigger one, then
acute pulmonary embolism produces a right ventricular failure. That is cor pulmonale. What will be the ECG change in that? It's all same. What happens to the P wave?
P wave, P permit.
Very tall P
wave.
So these all findings are explained, but normally what we see is only tachycardia. That is the commonest finding. Okay. Any arrhythmias are common in pulmonary embolism? Atrial fibrillation. Okay. Continue.
We had planned after finding out the DVT, we have planned for a CTP and sent for planned for CTPI to see at which level the thrombus is present. Okay. Before shifting only, we can start with the anticoagulation of heparin. 5,000 units subcutaneous heparin can be given.
Per kg body weight dose?
Per kg body weight, 18 units per kg.
Bolus?
18 units per kg.
80 units per kg bolus and 18 units per kg infusion per hour. Okay. Myocardial infarction dose is slightly different, 60 plus 60. But we don't see that we normally give 5,000 units TID or infusion. Okay.
And then CT was done. In CT report, we had seen that there is a right-sided pleural effusion. Along with that, right-sided lower bronchial trunk pulmonary embolism was present.
Okay.
As the patient is hemodynamically stable, further...
What unstable findings can be there in patient because of
severely tachypnic.
That is not unstable, no?
Hemodynamically unstable in like hypotension.
Hypotension is the most important problem in emergency room because of massive pulmonary embolism. Okay, how do you tackle that? Patient develops pulmonary embolism induced hypotension. What do you do?
First, if we need to increase, we can give bolus fluids. First
fluids are the treatment of choice, whatever it is. If there is hypotension, fluids are the treatment of choice. Okay, then because of distension of the... What happens to left ventricle in massive pulmonary embolism?
Hyperkinetic.
What happened to left ventricle?
Hyperkinetic.
What happened to the ventricular septum?
It will be pushed towards
the R from RV, it will push towards the LV. So if you give fluid, sometimes this fluid can reach to LV and can produce some amount of pumping. That's a like main thing behind giving fluid. Okay, you give fluid, sometimes patient will improve, sometimes patient may not improve. It will not harm the patient. So fluid can be given then.
Then first initially if the BP is below the systolic BP less than 100, then start with NORAD. Once NORAD, with the help of NORAD, BP crosses 100 systolic, then we can start dobutamine to increase the heart's contractility. Then at the same time we can plan for a mechanical thrombectomy to be done.
If the patient is having hypotension, shock, then mechanical thrombectomy, if that is available in your center, then that can be tried. Otherwise, only fluid and noradrenaline with heparin infusion will be useful. When will you thrombolize the patient? Suppose you don't have a mechanical thrombectomy in your state, center.
Then we can plan for
The
thrombolysis.
patient is in hypotension, shock, you are not able to revive the patient, massive pulmonary embolism, then you have to thrombolize the patient. Okay. So most of the centers will have thrombolysis than thrombectomy. Some centers will have thrombectomy also. In that condition, we can take. Okay.
Thrombolysis, we can with RTPA, streptokinase RTPA, we can give as initial as 0.6 mg per kg over 15 minutes, and then infusion we can start.
Okay. That is indicated in?
Massive pulmonary embolism with unstable massive.
Okay. Unstable massive pulmonary embolism, we have to give that. Okay. Then, what are the other things you consider in pulmonary embolism? What is pulmonary embolism rule out criteria?
Initially, when we use
that all things you will be useful in emergency room.
First, initially, when we have a patient, when we are suspecting pulmonary embolism, we do the Wells criteria.
Okay.
Then we divide it into two groups, likely or unlikely. That is depending upon the score of greater than 4 or less than 4. When there is an unlikely case of pulmonary embolism, we can use pulmonary embolism rule out criteria, PERC criteria, which is consisting of 8 components. If everything is negative, all the factors are negative, then there is no need to go ahead with the evaluation of the pulmonary embolism. No need to send D-dimer, no need to go with the...
Okay. What is VQ scan?
VQ scan is a ventilation perfusion scan. It is used in pulmonary embolism in those cases if it's a pregnant female, young.
If CT is not indicated,
CT is contraindicated because of high create ratio, then we can go with ventilation perfusion.
What is this ventilation perfusion?
It's a functional scan using nuclear based radioactivity.
That is called as ventilation perfusion mismatch. What is this mismatch? Where all you get mismatch? What are the types of mismatch? 2 types is either ventilation, if present and no perfusion, then it can be pulmonary embolism. If perfusion is present and no ventilation, it can be pneumonia. Pneumonia. Okay. So you see a white shadow in the chest and you are thinking pulmonary embolism. If you do VQ scan, you can see that ventilation is preserved, perfusion is reduced. That is called as VQ mismatch. Okay. Suppose you do VQ scan in this patient, what else you can pick up other than that? Because this dye, whatever nuclear material, they start from the lower limb.
Yes.
That from lower limb itself, they'll take the scan. So even if there is a block in the lower limb veins, that also can be picked up. Anywhere in the body, any other blocks, that also can be picked up. That is the advantage of VQ scan. You will be scanning the whole body. Okay, nuclear, but that center should have nuclear medicine. Okay, then it is possible. Okay, in our hospital it is there. So if you want to suppose you are not able to take any patient for CT scan due to any reason, we can go for that. Okay. What may be the reason for, what is the trigger for pulmonary embolism in this patient? How do you prevent it?
In this patient, as there is obvious indication of DVT which started 3 days ago, highly likely that the DVT, the thrombi of the DVT is...
What do you think the trigger is? And how can you prevent all these things?
Trigger would be a procoagulant state because of the cancer.
She's already having a procoagulant state. And on top of that, she was admitted in a hospital for 2-3 days. In that situation, what you should do to prevent that? When any patient is admitted to hospital for more than 3-4 days, and who is having a procoagulant state in the past, how can we prevent it? You have to give DVT prophylaxis. Any patients admitted to hospital, especially in ICU, who is not moving and who is already having a procoagulant state, it is always better to start heparin as a preventive dose. What is the preventive dose? If you are giving conventional heparin, what is the dose?
5,000 TAD.
5,000?
TAD for
okay.
Preventive dose,
Okay.
5,000 BD.
Okay.
And also you can give pneumatic compression stockings.
Compression stockings have got no role in preventing DVT. It's not used for prevention of this one. What else you can advise the patient? Compression stocking is only a compression stocking. Mobilization. You ask the patient to move the lower limb. That is the most frequent area you get DVT. So movement, mobility and heparin will help you to prevent it. Compression stockings, traditionally it is given, but the role is not very significant. That you should remember. Okay. Then What are the other procoagulant states, you know?
Like factor 5.
Where is compression stocking mainly useful? Which conditions? Huh? So it is useful whenever there is a fluid retention in the lower limb. Okay. So what happens? Suppose you have a lot of fluid retention in the lower limb, especially in diabetic patients. You are seeing cellulitis, ulcer, cellulitis. So to prevent that, compression stockings are very good. But pneumatic, you may be thinking about pneumatic compression. Okay, that is a different thing from your compressing stockings. Okay, what are the other procoagulant?
Other procoagulant states are factor 3 deficiency, protein CS deficiency, antiprothrombin deficiency.
Factor 3.
Factor 5, sorry, factor 5.
Factor 5. Antithrombin deficiency, protein C, protein S deficiency, antiphospholipid syndrome antibodies. So what procoagulant workup you have done for this patient? Is it done or not done?
This patient,
What you will do?
in this
What
patient
you will
we
avoid?
will send this factor level,
Factor 5.
factor 5 protein CS levels, antithrombin 3 levels, APTT PTI.
APTT PTNR is for what? To start apparent, you want to know what is APTT. That's okay. Suppose protein C, protein S is reduced here, antithrombin is also reduced here. What is your
in the acute
diagnosis?
phase, like on diagnosis, at the time of diagnosis, they might be reduced because it's used up for the.
When there is a massive pulmonary embolism or massive DVT, to lyse that, all your protein C, lyse and regeneration of thrombus, all your protein C, protein S, antithrombin will be utilized. So acute condition, it will be low. So even if it is low, you cannot make a diagnosis of protein C, protein S and antithrombin deficiency. What is the problem of doing that test in the acute phase?
Then we will diagnose it is because of protein.
Mostly we will brand that patient as a protein C, protein S deficiency. Lifelong this patient will be on warfarin or something. Okay. To avoid that acute condition, you don't do that. Suppose you are doing it, if the levels are normal, then that is ruled out. That condition is ruled out. No need to do it again. But the levels are low, again you will have to do it after some time. So how long you continue warfarin or dabigatran? What is started to prevent?
Here initially started given start dose of heparin, but then later started with an oral anticoagulant of apixaban.
Apixaban is started. So how long you continue apixaban in this patient? It is not
First
emergency
BD
doctors.
for 5 days, then OD for next.
How long means how many days, how many months you continue?
Continue for lifelong.
Lifelong. Normally, unprovoked DVT without any reason like this, you don't know what is the reason. 6 months is enough. And you have a probable reason that she had a malignancy
DVT.
and she is bedridden for last 3-4 days in hospital. So that may be the trigger. So 6 months minimum you have to continue. Okay. Suppose you found out that there is a protein C, protein S deficiency after 6 months, then lifelong has to be continued. Or if it is due to antiphospholipid antibody syndrome, that also you have to continue lifelong. For antiphospholipid antibodies, is it a genetical problem or acquired problem? Acquired or genetical? Antiphospholipid antibodies.
Both.
Both. It can be both. It can be a genetical problem, a part of other diseases, and it can be acquired after infection or something, accident, trauma, and all that. Or there also it can be formed. Okay. So in that condition, you have to continue for lifelong. Suppose the patient is having lower limb or lower abdomen malignancy, and recurrent thromboembolism is coming from that area. What do you do?
IVC filter.
IVC filters can be tried. Okay, so what is this patient finally? This patient is a DVT, and trigger factors are bedridden for last 2-3 days, and the problem behind the DVT may be a malignancy, pre-existing malignancy, bedridden patient, lower limb thromboembolism, from there pulmonary embolism, and we have given heparin. Since she is not in shock, we have started heparin. Suppose she have hemodynamic instability, then you let start Thrombolysis. Okay. Will you follow up this patient?
Yes, I followed it up after discharged her on Epixab and OD dosing.
Okay. Suppose this patient bleeds after sometimes and come back to emergency room. What is a reversal agent?
Epixab and reversible agent is.
That you had to read.
Yes,
That is a homework. So this patient can come back to emergency room with an acute bleeding. So you'll have to reverse that agent. Okay. So that is also very important. Heparin, what is a reversal agent? Protamine. Okay. Low molecular weight heparin. There is no specific agent which can reverse, but protamine can be tried. But there is no specific agent like protamine in heparin. But that there also you can try it. It is very, very rare that low molecular heparin can produce a clinical bleeding, but even then it can happen. Okay. Okay. Thank you.